So our first speaker today is Dr. Franklin Huang. He's a physician scientist and a member of the genitourinary oncology division at the Dana-Farber Cancer Institute. His research focuses on two primary areas: improving the care and treatment of underserved cancer patients using cancer genetics and genomics research and technologies, and understanding the genomics of prostate cancer in African American men. He is also the co-founder and co-president of Global Oncology, which is a nonprofit organization dedicated to bringing the best cancer care to underserved patients worldwide. Dr. Huang is also a member of the Center for Future Technologies Cancer Care Clinical Needs Assessment Corps. So without further ado, I will let him come up and talk with us.
Thanks, Helen. Again, I'd like to echo Kathy's point about getting in touch with the center, whether you're an engineer, a scientist, or clinician, to find out about how you can interact with others in this network to move towards developing new technologies for a much-needed population, especially as it relates to cancer care and global health. This is a picture just of I think of this picture. This is of a drop of blood actually in Uganda, taken with an iPhone of a patient with AML. And I think about this because I spent time sending this to colleagues here in Boston, trying to help with the diagnosis and then come up with the treatment. We ended up wanting to get ATRA for this patient. Even though the patient in the end did not have APML, the point here is really that within this continuum of trying to, at the point of care, diagnose a patient, deliver the right treatment for that patient, and having the means and the resources to do so is extremely challenging. And you improvise quite a bit. So my goal today is really to set the stage for the other speakers, and to provide a framework. And really what I want to do is help you think a bit about where care is delivered, how care is delivered, and who's delivering the care as you thinking about collaborations both between engineers and clinicians, but also with partners on the ground where ultimately we hope to have benefit the patients. So probably not a surprise to most one, and I'll go through these very quickly in terms of the rising global cancer burden, but this data just out from IHME, published in JAMA Oncology this week, really highlights the rising global cancer burden. It's the second leading cause of death globally. It's on pace to take over as number one, and cancer cases rose 33% worldwide in the past 10 years. And in 2015 alone, there were about 18 million diagnoses and almost 9 million deaths from cancer. And of course, this burden is going to increase over time. And this is data from GlobalCan showing you that really the less developed countries in the world really will bear the brunt of this epidemic and pandemic of cancer, and that they are often not equipped to handle the burden that's coming and currently existing. Cervical cancer will be discussed later in more greater detail and in much more granular fashion, but really this is to highlight that cervical cancer, at least globally we think about it, really is still a major burden among women in low and middle income countries, and it is really the top cause of cancer death in about 50 countries, and that's highlighted in the sort of orange-yellow color on this map. And really, the challenges that we face in thinking about cancer care in the global health setting is reflected somewhat in this table. This is from the DCP3, where we really look at the lack of resources to commit to be able to engage in high-quality cancer care. If you think about surgical capacity, the surgical facilities, and if you look at the two columns in the low income, I apologize that it's so small, low-income and lower middle-income countries, there are really drastically fewer surgical facilities. The out-of-pocket health expenditure for patients is quite high. And then a drug that we commonly use here for adjuvant and metastatic breast cancer, tamoxifen, is not readily available. And not just that, but that the ability to diagnose ER-positive breast cancer is very limited in low-resource settings in sub-Saharan Africa and other places. And again, not to forget about what we often face in terms of advanced cancers is that the availability of oral morphine is quite limited as well. And the income range, again, to show you, in low-income countries is about $1,000 per year and below. So what are the considerations for clinical needs? Again, I'd say, where is care delivered? We think about the dedicated space for cancer care. I'm always reminded of chemotherapy mixing that in certain places occurs in the same location that patients are being treated, which is not ideal. And the clinics, the hospitals, and the home and the community where patients are managed, are diagnosed, and how they move between these different elements of the care spectrum is an important thing to think about. And then I think, who is providing care? Often there's clinicians, there's a severe lack of shortage of oncologists and surgeons and other point of care clinicians, but then nurses and then family caregivers, which is a very primary point of reference for who's taking care of patients with cancer, especially in the hospital in these low resource settings. And that's something that we often don't sort of consider as much about the types of care that are given. And then thinking about what are the current capacities, demand, and barriers for care. And here we're thinking about what is the actual, clinical and patient workflow, what are the types and numbers of patients that are occurring, data that we need from registries, data that we need from ongoing assessments of what types of patients are walking in the door, and that we often have these burden of disease estimates that come from groups like IHME and WHO and IARC, but really understanding what the burden of disease is in a local community. And then thinking through what is the available equipment, electricity, Wi-Fi, AC, how do you think about designing solutions to the problems at the point of care in the specific context that you are addressing? And so here I've just listed a list of some of the gaps in essential cancer care services in low resource settings specifically, both based on data that comes from literature but also anecdotal. And again, we think about, if we just bin these in very big categories of diagnosis, and by diagnosis I really do think that we want to think about early diagnosis and early detection, as well as precision and being precise with that diagnosis. What are the pathology services that are needed? Clearly, immunohistochemistry and molecular diagnostics plays a critical role. Imaging and or the lack thereof. And then really the highest priority is the lack of human resources. There really just aren't enough staff to fill in the gaps of cancer care in many different settings. So I'm talking about nurses, medical oncologists, social workers, pharmacists, technical staff, and then the equipment and reagents and the flow of those to the site at the point of care. When we think about treatment, we think about, here in this building and in other major cancer centers, you have specialists who can tell you specifically how to treat prostate cancer. And I think as you go out into the global health setting, that is much more limited, and you're thinking about the essential the type of model of community oncologists or oncologists in the community who would need to treat a whole range of types of cancers. Again, thinking about the space in which to perform and mix chemotherapy safely, the availability of both chemotherapeutic agents, biologic agents, and also of radiotherapy, which are huge issues that are being tackled in large commissions, especially by the Lancet commissions. Surgical care is a major issue, and there are global surgery efforts that I would point you to. And then I think some of these other efforts, such as difficulty with coordination of care. Coordination of care is a major challenge in global health settings, and it often falls to the patient and to the family caregivers to really push their family member forward. In terms of care, Kathy mentioned the monitoring of side effects, the monitoring of treatment outcomes. There's very limited data, extremely limited data on the outcomes of patients in very low resource settings when they're being treated for various cancers, whether or not first line, second line, third line therapy is appropriate and working. And then thinking about patient and caregiver support. These are all important issues that technology, innovation, communication can all address. So where are the potential opportunities for innovation in technology in cancer care? And I use this, this is not an exhaustive list by any means, but things to sort of jolt you into thinking more about it. Thinking about cheap and easy-to-use diagnostics at the point of care. In fact, I was just texting with my colleague in Malawi this morning about, what should I tell an audience of clinicians and engineers? And he said, bring high-tech diagnostics to us that we can use. Patient navigation is very important. Patients often can get lost to follow-up. There just aren't enough resources to continue to track patients and help them continue to be a part of the medical system. Monitoring and follow-up. Technology to support decentralized cancer care outside of tertiary care centers, including screening and early detection and communication with those clinicians and teams at tertiary care centers. Diagnostics in a box, pathology that can be done at the point of care that can help diagnose a patient with their tumor as opposed to waiting for weeks or months before a diagnosis is returned, and then you risk patient delay, treatment delay, and obviously the downstream effects of that with poor outcomes. I think that there's an opportunity to really think about methods and tools to help clinicians monitor and maintain communication with patients. Most folks in low-resource settings will have some type of mobile phone, and that is certainly an opportunity to provide communication with treatment teams and their patients. And then things like mHealth tools for decision support, clinical clinicians, community health workers who are going out into the community, who know the communities. And then thinking about mHealth tools for both patient and caregiver support. Another one I added here is thinking about the role for precision cancer medicine in low and middle income countries. There's an opportunity to think about delivering the right treatment to the right patient at the right time, which we think about in precision cancer medicine. And in low resource settings, thinking about, are we making the right diagnosis and how can we give them the best treatment? So this is a slide from my colleague in Malawi, and this is about dealing with skeptics. And Malawi is one of the poorest countries in sub-Saharan Africa. This is the largest hospital in Malawi, in Blantyre, and this is a patient who presented with non-Hodgkin's lymphoma, obviously a very massive mass of lymph nodes in the neck, who then successfully underwent chemotherapy. And he calls it dealing with skeptics because I think that they're under tremendous constraints to provide cancer care in these settings, but yet they believe deeply in what they're doing. And so I'll focus on Malawi just for this talk to talk about understanding the clinical needs and the importance of partnership with thinking about what is the local community and environment in which you'll think about designing solutions. This is informed by our experience at Global Oncology, thinking about how to advise on difficult cancer cases. Here you can see clinicians in Malawi huddled in, this is their old cancer ward, communicating with us here in Boston with an expert to advise on a case and do some teaching. And this is a very just straightforward video conferencing way to advise on difficult cancer cases. But through that process, you really begin to think about how to collaboratively design, iterate, understand the needs at the point of care. These are some of the colleagues both in Boston and in Malawi. And then that really interacts with the idea of the designers, the public health experts, nurses, health communications experts, and then importantly engineers here where you can build teams to think about how do we address some of the problems and the challenges that we're hearing through this. I'll give you one example, a very low-tech solution that we undertook. It's a case study, and we heard from our nurses and clinician colleagues that they lacked patient educational materials for the patients, and so we worked with a design firm here in Cambridge called the Meme to design, I apologize for this, to design easy to understand, visually guided cancer chemotherapy guides. And this was then piloted in both Malawi but also in Haiti, and now is being piloted in Rwanda. It's been translated to 6 languages. So a very straightforward way of trying to understand some of the challenges and addressing them with a team of experts and other types of professionals. I would do a small plug for thinking about finding collaborators and needs in global cancer care. This is the Global Oncology Map that we developed with support from the NCI Center for Global Health to basically catalog and document the different types of research, cancer control, capacity building projects in the world. And you can search this map and look for different collaborators, who's working on what and what type of specific areas. I will say that a new version of the map is going to be launched in 2017, and it's meant to be more of an interactive network and community platform. So again, going back to the idea of, where is care delivered, by whom, and how, and then going from the first mile to the last mile. And I think here is where we think about the opportunities both from the home. If you think about where the patient lives in a low resource and low income country, to the clinic, and then to the hospital, where are the areas for opportunity to really reduce the barriers for those patients and to get them the right diagnosis and the treatment that they need. We think about the delays to diagnosis that occur. We think about the delays in treatment that occur going from clinics, patients bouncing around before they finally see a person who can accurately diagnose them. So what could innovation at the point of care look like, and what could the future of cancer care look like in low resource settings? I throw this up here because everyone should recognize that this is the famed nanotainer that never really existed. But if you think about diagnosis, whether it's a blood test, whether it's a biopsy, a breast cancer core biopsy, or a bone marrow biopsy, you think about what does it go into, and how do we create devices and think about solutions that can reduce time, save costs for patients and for clinicians and these healthcare systems that don't have tremendous resources. Think about cloud pathology. Think about how that integrates with clinicians, nurses, technologists, community health workers. Think about, could they have a shared plan of care that allows them to both understand what the plan is for that patient, what the plan is for the patient to follow up, and monitoring of that patient. And that would then interact at the site of where? At the clinic, at the home. And then thinking back about how does that feed back, and I apologize for that, but that the community health worker would be based in the community and could feed that information back into the healthcare system. So I just leave with this sort of thought, which is that there is a lot of emphasis on medicines and the need for essential medicines, cancer medicines in countries. Cancer medicines are obviously very expensive here as well. But I think at the end of the day, you think, and I'll just read this, you can have Gleevec, but you cannot do a bone marrow for a number of different reasons, for not having the biopsy kit, for not having the person to do the biopsy. And the biggest challenge that they've had for 6 years is not being able to do that. Medicines can only be given if the proper diagnosis is made and there are people who can prescribe it and monitor it. And I'll end there. Is there any questions?
Are there any questions for Franklin? Go ahead. Just repeat the question.
Okay.
Yes.
So you mentioned in one of your last slides this idea of cloud pathology. Could you explain a little bit more what you mean by that?
Yeah, so I think that there's an opportunity on a number of different levels to send images into the cloud and to have an expert pathologist read that image. And it's being done in various different capacities. It has been being done for several years in a number of different sites, whether it's dermatologic pathology, other types of biopsies. You have to process, ideally you process the tissue at the site, it goes into the box, that box then sends that image into the cloud, and then there is a team or a group of people that are responsible for reading that image and providing that information back. So that's what I think about in terms of cloud pathology and cloud diagnostics. Oh, so the question is about increasing cancer incidence over the last 10 years. I think that and I'm not an epidemiologist, but I think that in large part is due to shifting trends in terms of whether you want to call it westernization or globalization, and that there are, diets are changing, overall life expectancy is increasing, and there's urbanization at play as well. So we haven't done away with tobacco anytime soon, so that is continues to be a large driver of cancer incidence. So I think that those are some of the major factors that are driving that change. Well, yeah, it's not necessarily genetic from germline genetics per se.
Thanks for a great talk. I was interested when you spoke to your colleague in Malawi about, and you asked him what it was that he wanted or needed, and he said high-tech, did he say diagnostics, or, yeah. Is that really, in terms of trying to reach the most amount of people and trying to get population cancer under control, is that, do you see that as what's also the most important thing?
Well, I think that's one part. I mean, I think he was being informed by, the audience was going to be clinicians and engineers in thinking about what that would be. I think that, obviously underlying this is tremendous poverty and lack of resources in these countries. I think that if you were to ask them, like, what would be the number one thing, it'd be, I need more people, to take care of these patients. And that obviously requires staffing, money and staffing to do such a thing. I think in terms of the technology solutions, I think that, allowing them to make the diagnosis easily and be assured that they have the right diagnosis, I think is a major thing, at least from the clinician standpoint. But I think there are many aspects within the systems that can be improved that would, greatly benefit patients over time.
You obviously made this presentation cancer specific, but I was wondering if you could give this exact presentation and make it medicine in general, or is there something specifically about the cancer that is?
Yeah, that's a great question. I mean, I think that we don't want to live too much in our silos of thinking of disease, and clearly cancer is part of this large bucket of non-communicable diseases. I think you're right. I think that there certainly are ways in which you can think about the process, but I think that if you think about a health system that can take care of a cancer patient and deliver high-quality cancer care, I mean, that's a pretty robust system, right? It has to have radiology, it has to have surgery, it has to have medical oncology would give chemotherapy, it has to have nurses, technologists. So I think that cancer is a great example for really thinking through, what is a robust healthcare system that can deliver this type of care. HIV care, for one, can be very direct, and you certainly are going to be delivering antiretroviral therapy to many millions of people. But again, I think the spectrum of services that need to be available to deliver cancer care is quite extensive.
Okay, well, let's thank our speaker again.